And here second video of medical education series I am presenting. I hope I can make useful contribution, and if viewers learn few things from these high yield fields of research and medical education, my goal of uploading these videos will be achieved. So this video is about curriculum strategies in a SPICES model. With recent advances in medical field and rapidly evolving dynamics of medical education, Harden and his colleagues proposed 6 educational strategies that can be used in curriculum development, curriculum review, planning, tackling problems in curriculum, and providing guidance relating to teaching methods and assessments. Now look at the SPICES 6 strategies. On extreme left represent the new innovative curriculum, and on the extreme right the more traditional strategies. Now it's not all or none model. You can tilt towards the left in few strategies and tilt towards the right in few according to your college curriculum requirements. Now let's discuss in detail the SPICES model. SPICES stands for Student-Centered, Problem-Based, Integrated, Community-Based, Electives, and Systematic. On a traditional front is teacher-centered, information gathering, discipline-based, hospital-based, standard program, opportunistic, or apprenticeship-based. Now student-centered curriculum means students' opinion is essential, that how and what they want to learn. Students are responsible for their own learning. Student is the central figure, not the teacher. Under the teacher guidance, students make learning objectives, select appropriate learning resources to achieve these objectives, decides the pace and sequence of their learning, and assess their progress. So active learning takes place. Whereas in teacher-centered traditional approach, teacher is the central figure. As we all know, we are teaching traditionally since many decades. He decides what to teach and how to teach. He controls the sequence and pace of learning and decides the time of assessment. So passive learning takes place. Course is not published. To discover what they require to learn today, student must attend the lectures. So in summary, student-centered has emphasis on the student, promote active learning, promote responsibility and motivation in students. In teacher-centered, favor experience of teachers, has no match, fewer demands on teachers, less resources are required in teacher-centered programs. Now I hope it is clear that what is the student-centered curriculum and what is the teacher-centered curriculum, and the shift toward the student-centered curriculum is the need of the hour. Now let's come to the second point. Problem-based learning means to use it as a vehicle to develop a usable body of integrated knowledge and to develop problem-solving skills. In problem-based approach, students tackle patients' problems, health delivery problems, medical science problems, or research problems. I will give an example from my specialty. A 60 years old male patient, known diabetic, presented with the droopy right eyelid and restricted ocular movements. The eye is down and out. Now student must know the effect of diabetes on the eye. He should know diabetes mellitus as a disease and its effect on vessels, and he should also know that droopy eyelid with restricted movement means third cranial nerve palsy. So he should know the anatomy and physiology of all the cranial nerves and which cranial nerves supply the eyeball movements and the upper eyelid, and what are the normal eyeball movements, and how diabetes cause cranial nerve palsies. So It's an interesting scenario for patient that for students that from a patient he will learn different anatomy, physiology, pathology from a scenario. In contrast to problem-based learning, traditional information gathering or knowledge collection, you will teach anatomy of the eyeball in the same scenario, physiology of the eyeball, pharma, biochemistry, separately all the cranial nerves in neuroanatomy, and major objective will be acquisition of facts, concepts and principles. Now they will separately be taught, and then patient will gather by himself all the knowledge and apply. Now the third strategy is about integrated teaching versus discipline-based teaching. Nowadays trend is more towards the integrated teaching. Integration may be horizontal or vertical. Horizontal integration means in first 2 years integration between anatomy, physiology and biochemistry. Like if musculoskeletal system is started, all these departments should integrate and should parallelly teach same system and within the same system the topics. Vertical integration is integration between disciplines traditionally taught in different phases of curriculum. More emphasis is placed on basic sciences in the early years and clinical sciences in the later years. Sometimes we incorporate both horizontal and vertical integration curriculum together. Example is that nervous system is started and structure and function of the nervous system with clinical neurology, and diseases of brain and spinal cord are taught by neuroanatomists, neurophysiologists, neuroradiologists, neuropathologists, neurologists and neurosurgeons. To reduce the fragmentation of medical courses, integration is necessary. It motivates students, it improves the educational effectiveness of teaching, it promotes staff communication and collaboration between the basic and clinical sciences. In traditional discipline-based systems, teachers are experienced, comfortable, the course is less complicated, more topics are taught, less resources are required, better teaching. If a student wants to pursue career in basic sciences, he or she may be lost by not seeing discipline-based departments. Content of the discipline may be neglected in integrated system. So these were the advantages of traditional based system. Now the next point is in SPICES is community versus hospital based. In community based curriculum, students experience health related problems in community. They visit basic health units, rural health centers, works with general practitioner, helps him in dealing patients, understands patients problems, appreciate how community functions, develop bonding and affection for community people, gain useful learning experience, encourage active learning. Hospital based curriculum is also very important. Structured learning environment is present there, diagnostic facilities, major surgical procedures, major clinical skills are acquired there. More qualified and trained teaching staff is there in hospital based system. More concentrated form of experience is gained. Specialist career can be adopted by working in hospital. Educational advantages like small group discussions in wards, OPDs and theaters is done in hospital based system. Now the next point in SPICES model is electives versus standard programs. In a standard program, all the students pass through a set of prescribed courses with little choice to study in depth subject of their own choice or liking. Recently trend is going towards flexible curricular programs. Electives are a way of coping with an overcrowded curriculum. It allows students to choose subjects in which they want to specialize. It can bring about positive attitude change. Electives can be intercalated years of study in curriculum during which time students can select one or more subjects to study in depth. Electives can overload teachers with work. Now that's the disadvantage. It requires more resources, specialized staff may be trained in standard teaching programs, so there will be lack of motivation, lack of interest, and lack of awareness in elective programs. So staff should be trained in electives. Assessment of elective work is also difficult, and electives can affect other coursework. Now the last strategy is systematic versus apprenticeship. I will give you my own example that I got a training in ophthalmology in oculoplastic unit under one supervisor. I spent 4 years, so I had learnt a lot more than required oculoplastics, but I had deficiencies in other subspecialties like vitreoretina, cornea. So there is now a strong belief that what the students do, see and do should no longer be left to chance, and in a planned or systematic approach, a program is designed as such that all the areas necessary to be trained in are covered in given time. Like in my specialty, there should be 6 month rotation in oculoplastics, glaucoma, cornea, retina, pediatrics, uveitis, so general ophthalmology. So every aspect is covered. So students experience a variety of health problems, rationalization of competencies. Like in ophthalmology, a cataract surgery must be learnt, and trabeculectomy or DCR may or may not be learnt according to the time. Rationalization of time, like students become confident with proper exposure to the whole field with least waste of time and resources. Now there are advantages of apprenticeship as well. You learn in depth everything in a specific field from one teacher. Bond is stronger with the teacher because you spent more time together. There is continuity of teaching. So in summary, both new and traditional systems have advantages and disadvantages, and we can choose in each strategy that where our curriculum should tilt towards left or towards right, and accordingly we can make teaching methods and assessment plans. So that was a SPICES model, 6 curriculum strategies, SPICES model. I hope you can learn something from this video. Thank you very much.